Hi everyone, this is Divya from Quickmommyhacks, and today we'll talk about nocturnal enuresis or bedwetting in children and how it affects the self esteem and mental health of a child. To discuss this topic, I have Dr. Nisha Deshpande with us today. Dr. Nisha is a practicing pediatrician and pediatric neurologist from Pune, India. She completed her MD in pediatrics in 92 from Government Medical College, Aurangabad, and she has worked as an assistant professor for 5 years. And then she got trained in pediatric neurology from London Health Science Centre, University of Western Ontario, Canada. And she has been practicing in Pune since 2006. She's a member of Indian Academy of Pediatrics, Indian Epilepsy Society, International Child Neurology Association, and she is an ex in charge of Pune Neurology Chapter of Indian Academy of Pediatrics, and she's currently the vice president of Child Neurology Society, Pune Chapter. My first question
Sure.
for the topic, which is what is exactly nocturnal enuresis or when is bedwetting in children a concern?
Now, actually, nocturnal enuresis, as the name itself suggests, it is intermittent bedwetting or intermittent urinary incontinence during sleep in children at least 5 years of age. Though around 5 to 10% of 7-year-olds also do have bedwetting or nocturnal enuresis.
Mhm. So, how common is it, like in generally in population in India or worldwide? If you could give us some.
It's 1.4, 1.5 to 28% worldwide prevalence. And in India, it's somewhere around 7 to 15, 16%. So as you see, it's pretty common.
Mhm.
But the good thing about it is almost 12 to 15% of children, the situation resolves on its own.
Mhm.
But very few, as in around 2 to 3%, even take it till adulthood.
So, why do you think like bedwetting in children, beyond a certain age, why is it considered a social stigma?
Social stigma, the way you call it, it is more because of the embarrassment. Now when the embarrassment factor comes, it's, see, in younger children they are not that aware, so for them it's a routine, or they don't take it much in a negative manner, or they are not actually embarrassed. It's more the parents who are embarrassed,
Mhm.
and that's how they talk about it, and then the kids get embarrassed, and then it starts getting discussed into the social or the family circles, and that's how it becomes a sort of a stigma that the kid is sort of bedwetting till an age when he should already be dry by night.
So, can you tell us a little bit more about, what causes bedwetting and, how it can be diagnosed?
Yeah, so basically when we say bedwetting, it is we divide it as either primary nocturnal enuresis or a secondary nocturnal enuresis. Primary is the child has never achieved 6 months of dry nights and he's always been wetting the bed since the beginning.
Mhm.
But secondary is the child has achieved 6 months of dry nights and has relapsed again.
Mhm.
So basically, it's either never achieved dry nights for 6 months plus, or has achieved and after 6 months or after more than 6 months has relapsed and started bedwetting again.
Mhm.
That is the secondary. The other way to divide from the medical angle is we call it monosymptomatic. As the name again suggests, monosymptomatic is bedwetting is the only symptom,
Mhm.
or it is non monosymptomatic where the child also has daytime issues, as in daytime wetting of his pants, or pain while urination, or say frequency of urination, urgency, dribbling.
Mhm.
These are the cases where we need to rule out the other organic causes, because when it comes to secondary nocturnal enuresis where the child has achieved 6 months of dry nights and then again has relapsed, usually there are most cases some psychosocial stressors,
Mhm.
which could be anywhere from the child's innate anxiety towards the environment, as in the school environment, somebody bullying him,
Mhm.
or study pressures, or stress of any type, sometimes changes in some family dynamics,
Mhm.
issues at the domestic front.
Mhm.
or even sometimes abuse in any form. It
Mhm.
could be a mental abuse or sexual abuse or abuse of any form.
Mhm.
So these are usually the secondary types of nocturnal enuresis. Now, when they are more than monosymptomatic, or as we call it, non monosymptomatic, where they are also experiencing daytime symptoms,
Uh-huh.
where they also have dribbling and urgency or frequency or painful urination,
Mhm.
or most importantly, in children, constipation, where they have less than 4 times in the week where they cannot go for clearing their bowels. So,
Mhm.
constipation itself is a trigger. So, these things wherein they have daytime symptoms sort of merit further investigations towards causes of the enuresis. Now, when it comes to causes, it could be simple urinary tract infection.
Yeah.
The child could have a UTI because of which he is experiencing enuresis. It could be constipation. As I said, constipation reduces the functional capacity of the urinary bladder. So you
Mhm.
treat the constipation and the enuresis later on gets resolved on its own.
Okay.
Secondly, there are certain behavioral or certain psychiatric illnesses, attention deficit hyperactivity disorders, or similar types of illnesses where also they have these types of enuresis.
Mhm.
Also, obstructive sleep apnea, where the children have sort of they get uh, sleep apnea, or sort of we get history of snoring.
Mhm.
These children often have enlarged tonsils or enlarged adenoids.
Mhm.
So believe me, when a child comes to us with nocturnal enuresis,
Mhm.
the first thing we would want to know whether it is just nighttime or it's daytime as well.
Okay.
It is daytime as well, then the workup or the causes really start from head to toe in the form of we need to see whether the child has enlarged tonsils, enlarged adenoids,
Mhm.
simple snoring, sleeping difficulty
Mhm.
can cause enuresis. From there, we go down, we look at any structural issues with the back. Sometimes we have to look at the back whether there is an issue with the spine.
Mhm.
And in this case, we call it neurogenic bladder. There are certain clues we get on examination of the spine, where you get a dimple at the base of the spine, where near the tailbone, or we get a tuft of hair near the tailbone.
Mhm.
So that means there is some underlying abnormality in the spine because of which the child has issues sensing, and that's why he is sort of either dribbling or passing urine involuntarily.
Okay. Mhm.
Then there are chronic kidney diseases. One is simple urinary tract infection, one is chronic kidney diseases, which might give rise to enuresis. Also, diabetes, also in children as it is in adults. Now, in addition, if the child also gives history of increased thirst, increased hunger, but weight loss, then
Mhm.
we have to look for diabetes and other causes. So
Yeah.
basically, anywhere from neurological to kidney to diabetes to psychosocial to behavioral disorders. Everything needs to be ruled out when it comes to nocturnal enuresis. It's not just the wetting of the bed or so called the stigma which you were talking about.
Mhm.
There could be a lot underlying.
You mentioned that sexual abuse,
Yeah,
could also
yeah,
actually trigger bedwetting.
yeah.
So, I mean, could you help me explain, like, how exactly?
Uh, well, when it comes to physical examination, basically, when we examine the genitalia, sometimes we see some excoriations in that area. You
Mm-hmm.
know, the vulval area, the perianal area, and that gives us a clue towards sexual abuse, and it warrants further evaluation.
Mm-hmm.
Now, the abuse can hurt the kid in two ways.
Yeah.
One is the psychological hurt, one is the physical hurt.
Mm-hmm.
So the physical hurt might cause some injury to the tract,
Mm-hmm.
which might cause this dribbling and painful urination and indirectly to enuresis.
Mm-hmm.
The psychosocial or the psychological trauma caused by the abuse
Yeah.
is good enough a reason to sort of upset the child mentally and so wet his bed. So
Okay.
it works both ways. Both the physical trauma can cause a literally a physical injury, which might cause a painful and a dribbling sort of micturition,
Yeah.
or the psychological trauma.
Okay. Okay. So, what are the risk factors associated with bedwetting?
Yeah. So the risk factors, as I said, first is younger age group.
Yeah.
For some reason, males are more predisposed.
Okay.
Presence of urinary tract infection, constipation, obstructive sleep apnea, as I said, in children who have enlarged tonsils or adenoids, diabetes mellitus, diabetes insipidus, all these spinal abnormalities which might cause, and surprisingly, a family history of
Yeah.
uh, enuresis
Hmm.
also is said to be a risk factor for enuresis.
Okay. Hmm. Okay. So, how can it be managed or treated?
Now, first and foremost, there are two ways when we approach any issue in children. See, the decision makers are the parents.
Hmm.
So, you need to first reassure the parents and counsel them first to handle the situation in a calm way.
Yeah.
Because, see, you should try to understand whether the bedwetting is actually bothering the parents or it's bothering the child.
Hmm.
If the child is too young and it's not bothering the child, I think the parents should just be reassured that most children overgrow these symptoms,
Yeah.
and medical, as in we call it pharmacological treatment, as in the medicines itself, will be needed only beyond 7 years of age.
Uh-huh.
Till that time, behavioral interventions are all that are needed. But what happens is with children, all the interventions are done with the support of the parents.
Hmm.
So if the parents are not supportive or understanding, or are continuously criticizing the kid about the symptoms,
Yeah.
things become a bit difficult.
Hmm.
So, first is you have to reassure the parents, you have to counsel them towards positive reinforcement.
Yeah.
What happens is behavioral, when I say behavioral interventions, few
Hmm.
basic things you have to do. One is you have to limit the fluid intake of the child
Hmm.
nearing the sleep time. Doesn't mean you have to give the kid less water, because the aim is not to dehydrate the child.
Hmm.
So what I tell them is, say if the child sleeps at 9, 9:30, 10 o'clock in the night, as far as possible after 7, 7:30, do not give any liquids.
Hmm.
Milk, water, juices, soups. Doesn't mean you have to deprive them of liquids. Just keep a record how much water does he drink after that time. If it is, say, 200 ml, 300 ml, 400 ml, make it a point that you replace that water during the daytime, somewhere in the afternoon hours, so that the child doesn't feel dehydrated and tired also.
Hmm.
So nearing bedtime, you have to limit the water intake. That is one. Secondly, just before going to bed, the child has to go to pee and sleep.
Hmm.
You have to wake up the child in the middle of the night, take
Hmm.
him to the washroom, and ask him to pee.
Hmm.
Again, there are two ways. You wake him up, walk
Yeah.
him to the washroom, let him pee.
Yeah.
Second is you lift him from his bed, make him sit on the pot,
Hmm.
then wake him up, then ask him to pee.
Okay.
Few children, they get irritated if you ask them to walk to the toilet.
Mhm.
As it is, as I said, we are dealing with the psychology of the kid,
Yeah.
and sometimes they don't like it. So it's better you lift them, make them sit on the pot,
Mhm.
and then tell them, come on, pee now, you're already on the pot. That
Okay.
is one.
Mhm.
During the daytime, there are ways to train the bladder, because basically sometimes the bladder capacity is less.
Mhm.
You have to train the bladder, ask them to drink a lot of water, and try to hold the urine as long as possible.
Mhm.
It's daytime, so whenever they feel the urgency, they can go and empty the bladder. What happens is that increases the capacity of the bladder.
Mhm.
And they can also teach them some sphincter control exercises.
Okay.
All these things would come under the behavioral interventions. And last but not the least, reward systems I have seen work very well.
Okay.
So you have to, without the child knowing it, keep a watch on how many dry nights. Suppose if he's passing urine in bed every single day, For 3 consecutive days, if he is dry by night, you reward him.
Okay. Mm-hmm.
What happens is, if he wets the bed, the parents are the first one to either criticize him or scold him for that matter, or even insult him.
Mm-hmm.
But if he doesn't wet the bed, he doesn't get patted on his back.
Mm-hmm.
Positive reinforcement, you positively say, wow, that's great. For 3 consecutive days you have not wet your pants, so you get a car today, or you get a toy today.
Mm-hmm.
So that, motivates them quite a lot.
Mm-hmm.
So these basic things for under 5,
Yeah.
mostly under 7 years of age, these works. Now, there are more complex behavioral interventions
Yeah.
which also can be done, which is something like a combination of: one is periodically waking the child to urinate, second is cleanliness training. Cleanliness training is when, if the child wets his bed, you make him clean the bed and put the sheet again himself.
Mm-hmm.
The purpose again is not to punish him. What
Yeah.
happens is, you tell him, come on, let's change the sheet.
Yeah.
He knows if I wet the bed, I have to do the sheet myself.
Yeah. Yeah.
And he doesn't like to do it.
Mm-hmm.
So don't make it a punishment. Just we call it cleanliness training. And third is possible use of bed alarm. Now,
Mm-hmm.
these bed alarms are the best and the most effective way of treating nocturnal enuresis.
Mm-hmm.
So, huh, the full spectrum therapy includes both daytime training for bladder, increasing the capacity of the bladder, daytime training for sphincter exercises,
Mm-hmm.
limiting the water intake, the cleanliness training, and the the last nail in the coffin is the bed alarm. Now, bed alarm, the basic principle is, there is a moisture sensor.
Mm-hmm.
That sensor is sort of put into the undergarments of the child, or sometimes even on a pad on the bed.
Mm-hmm.
And it is with a wire, or sometimes these days you get wireless also.
Mm-hmm.
Wireless connected to an alarm system.
Mm-hmm.
So when the child sort of has an accident,
Yeah.
the earliest detection of the moisture,
Yeah.
a loud alarm goes.
Mm-hmm.
That wakes the kid up,
Yeah.
and the kid sort of switches off the alarm. During that process, unknowingly, involuntarily holds that urine
Mm-hmm.
and switches off that alarm. By then, the parents also come over, they take him to the washroom, and
Yeah.
then he pees there, so the bedwetting is avoided.
Mm-hmm. Mm-hmm.
Now, the only thing is, if you opt for a bed alarm in areas where people have health insurance,
Mm-hmm.
these alarms are a bit expensive and are not covered under insurance. So
Okay.
it's a pocket expense for the parents. And secondly, you have to be patient. Once you start to opt for this bed alarm therapy,
Mm-hmm.
you have to go regularly for 3 months at least.
Mm-hmm.
Secondly, many a times the kids are deep sleepers. So the parents might want to sleep in the same room as the kid,
Mm-hmm.
so that they help him out
Yeah.
and take him to the washroom.
Mm-hmm.
After 3 consecutive months, you usually keep a track and call the kid for follow up, say every 4 weeks, to
Mm-hmm.
troubleshoot the problem. Sometimes there are some technical issues with the alarm. Sometimes the compliance is not good. The kid will allow to put that sensor for 4 days, and fifth day he'll say, I don't want it.
Mm-hmm.
Sometimes the parents forget it. There are multiple factors.
Mm-hmm.
So at 4 weeks, every 4 weeks, you see, after 3 months of use, most children, 50% children, have remission.
Okay.
And 14 consecutive days of dry nights, you
Mm-hmm.
declare them as in remission. And after that, you start, in fact, the other way we call it control learning, sort of,
Mm-hmm.
where you increase their liquid intake in the evening hours
Yeah.
and see whether they are still wetting the bed or not.
Mm-hmm.
So, this is how it goes. 50% of children have total cure, or total sort of uh, mm, nocturnal enuresis uh, healed with this itself. Remaining might opt for medications,
Mm-hmm.
and then there's a list of medical therapy for that.
Okay.
Rarely parents want quick answers, and they don't have this patience to go with 3 months of alarm and behavioral modifications and all those things, then they request and opt for a medical treatment. But given an option, medical therapy, as in desmopressin, some tricyclic antidepressants, they are given as far as possible beyond 7 years of age, if not never before 5 years of age.
Mhm.
So, this is all about sort of the psychological behavioral part of it. In addition, if the kid has any underlying cause for the enuresis, as I said,
Mhm.
any issue with the spine or constipation or behavioral disorders like attention deficit hyperactivity disorder or obstructive sleep apnea because of the enlarged tonsils, adenoids. Parallelly, we need to take care of those causes first. We can't just address the enuresis itself directly because we have to treat that cause first.
In your experience, like, you must have dealt with so many patients. What kind of implications have you seen bedwetting, has on child's social life, or, his behavior or his self-esteem?
Yeah. Now, again, it depends on many factors. One is the age of the child. Younger the age, let me tell you, better is the outcome because they are not aware of the sort of the seriousness of the situation. For them, I mean, it's okay. Second most important factor is the approach of the parents towards this issue.
Yeah.
If you make a big issue out of it, the kid keeps feeling guilty. What happens is if the child has any other issue, as in cold, cough, fever, vomitings, parents usually have a very sympathetic outlook towards the kid and they say, poor thing is not feeling well. He's not feeling well. But if he is wetting the bed, somehow the approach is as if he's doing it on purpose. The
Mhm.
parents have to understand he is not doing it on purpose. It is an involuntary thing. You have to help him out. You have to try to find out why is this happening and reassure him that it's okay. Even I did it as a kid and this will go away. So if you give him that confidence, because sometimes a little older children, if they come to know that none of their friends are wetting the bed but they are, somehow they feel bad about themselves, they start feeling guilty, they start getting a weird type of complex that they are some way different and different in a negative way from the peers.
Yeah.
And that, if these this thought process develops in, then it might be harmful to the psychology of the kid.
Mhm.
And even if he overcomes the enuresis, in
Yeah.
other areas, he always keeps feeling guilty, as if anything goes wrong, he takes it as if it's his fault.
Mhm.
So, here, as I said, the reward system and the positive reinforcement,
Yeah.
it helps a lot. And
Mhm.
here, the counselors have to reassure and counsel the parents more than the children. As I said in the beginning, we need to know whether the enuresis is bothering the kid or the parents.
Yeah.
And in most cases, it's bothering the parents more than the kids.
Mhm.
Kids, yes, if they are older ones. Then they come to us, they come to me and they'll tell themselves, I
Yeah.
don't like it. I wet my pants in the night. Can you help me, doctor?
Yeah.
Then I know he really genuinely is bothered and he needs help. And when he decides or she decides that, I mean, the kid needs help, they see to it that they work on it, provided the parents are supportive. That is the bottom line. Parents have to be non-critical,
Yeah.
rewarding, reinforcing the kid positively every time.
Mhm. Mhm. So, I mean, of course, like we talked about how it affects the child's self-esteem, and especially when they're older, it becomes like, a big issue. And, at that particular stage, when the parents keep on criticizing the child, it just really becomes, it develops something into their personality, is ingrained into their personality, which goes on into their adult life as well. So in those kind of situations, like, how do you think like parents can actually help the child navigate through that stage while the child is getting the therapy, in terms of also dealing with, peers around, or like friends around, or relatives, or people who might be subjecting the child also to a little bit of embarrassment?
Yeah, now this, see, The good old saying, what happens in Vegas stays in Vegas. So what happens in the kid's bed should stay in that bedroom. The peers come to know, the relatives come to know only if the parents talk about it outside. So the message for the parents is, if such a delicate issue, because from the child's angle, it is a very delicate issue. You might not realize it. You feel he or she is 5 years, 6 years. He doesn't understand. I mean, but no, he understands. For him also, it's something which is very, very private. So if you are talking about this private matter of the kid with anybody else but the doctor, they really, really feel offended. They might not be able to express it. So, the first step is you have to deal with the kid one to one, mother, father, and the kid. If you have another child, other sibling, even preferably, even he or she should not know about this issue. You have to handle it on one to one basis. If you do that, half the battle is won because the child has that confidence that you are here to help him,
Yeah.
not to criticize him,
Mhm.
not to talk about his private issue in public. When I
Mhm.
say in public, it is with peers, with relatives, with outsiders. So
Mhm.
half the battle is won. If you tell him it's okay, once in a while it happens
Yeah.
and it's okay. So he knows that no one else knows about it.
Mhm.
And when this happens, then you know the response of the kid to therapy, to the behavior interventions,
Yeah.
and the what you call the frequency and the what you call how should I put it? Basically, his own innate response
Mhm.
to accepting the treatment
Yeah.
and toward accepting his issues
Mhm.
becomes more positive, and so the response is early and better to all the interventions we do, whether it is a pharmacological intervention, that is the medicines, or it is a behavioral intervention.
Mhm.
So ultimately, it is the parents
Yeah.
whose approach is important in treating this child,
Mhm.
in addition to the health workers, as in the psychologist, the
Mhm.
doctor, and the medications, of course.
Mhm. So, as a medical professional, I mean, coming down to my last question, you must have seen a lot of parents and
Yeah,
also a lot of children, like new parents, actually. So,
yeah,
sometimes it happens that, when this problem develops, parents have a tendency to brush it off under the
yeah,
carpet. I mean, they don't acknowledge it, and sometimes they actually think that, it's just going to go away. And
yeah.
then it keeps on building up. So, as a medical professional, like, what kind of advice would you give to all the new parents who might have, seen this kind of a problem, and, like, how early they should act, and yeah.
Yeah. So basically, as I said, the first advice to the parents would be that it is very, very, very natural for children to wet their beds up to 5 years of age. Though it's 2.5, 3, beyond 2.5, 3 years, they gradually become dry by night. But then up to 5 years, it's natural. Toilet training also is an essential part of all this. So, as we all say, prevention is better than cure. Now, when I'm talking about this, it is understood that there is no underlying major cause for this enuresis,
Mhm.
as in a spinal cause, constipation, urinary infections, kidney diseases. These are all ruled out, and it is sort of a secondary type of enuresis where probably the child was 6 months dry and now has relapsed, wherein probably there are some psychological stresses involved. So you have to first introspect why this relapse has happened. Does the child have any stress on his mind? If so, from where is the stress coming? Is it coming from the home front? Is there an issue with the family dynamics?
Mhm.
Or it is coming from an external stimulus? If
Mhm.
it is an external stimulus, whether it is from peers at school or from peers in the society, sometimes they go for classes, they go to the park and play, somebody is bothering them, some stress. So,
Mhm.
first and foremost, Do not just pinpoint towards enuresis and keep nagging or scolding or criticizing the child.
Mhm.
Try to find out the cause. Try to introspect, because sometimes the cause could be some unrest at home itself.
Mhm.
Try to resolve that first. If it is not at home and you are sure that the family dynamics are perfectly fine, talk to the teacher. Ask the teacher if there is any issue at school. Try to take the child in confidence. Let him or her know that you are there to help,
Mhm.
not scold, not to criticize. You
Mhm.
are there with him or her so that the child feels confident to open up. And most cases, you will find some trigger towards that. And if you deal with the trigger, if you give him support, as I said, positive reinforcement,
Yeah.
some reward system, it's very easy to scold for the bad things, but one should also have those guts and courage to
Mhm.
pat them back if they do something good.
Yeah.
So, this is basically, honestly, not for just enuresis, it is for every parent to understand that reward them when it is necessary.
Mhm. Yeah.
Because you don't need an outsider to tell you to scold a kid when he does something wrong. Every parent does that. But
Mhm.
unfortunately, sometimes you have to remind the parents to reward them if they do something nice.
Yeah. Yeah.
So that would be my advice for the parents.
Uh-huh.
Be patient, be with them, let them know that you are supportive towards them. You
Mhm.
are you are their support. You are not just their critic.
Mhm. Mhm.
So that itself helps them and gives them a sort of that is their ray of hope, which tells them that bedwetting is not a crime.
Yeah. Mhm.
Create an environment where they start thinking that they have done a crime in that young age.
Mhm.
So I think that should help you try to understand them and be there for them,
Mhm.
and never forget that it's an involuntary thing. They are
Yeah.
not on purpose.
Yeah, yeah, yeah. No, I think that's a really good point that it's involuntary, and I think the parents also need to believe the fact that it's completely treatable. So, you need to actually seek help at the right time. So, it was really great having you. Thank you so much for all the information. It was really good. Thank you.
Thank you, Divya. Thanks a lot.
Yeah, thank you. Well, this brings me to the end of this video. Thank you for watching. If you like the video, subscribe to my YouTube channel, Quick Mommy Hacks, and follow me on Instagram for some personal tips on pregnancy, childbirth, and motherhood. Also, do leave your feedback and feel free to ask questions in the comment section below.